Hello, my name is Debra R, and as presented at NTI 2018 in Boston, we will be talking today about non-invasive assessment of cardiac output and fluid balance. Nursing is on the case. We will be covering identifying a patient's criteria and the type of patient who can benefit from non-invasive hemodynamic monitoring. Additionally, describe 2 hemodynamic functional assessments for providing guided fluid resuscitation. So what is this non-invasive hemodynamic monitoring measuring? And why is it helpful for us at the bedside? It provides stroke volume. By measuring stroke volume times heart rate, we now can determine cardiac output. It can measure systemic vascular resistance, which is the resistance the heart must overcome to eject blood with every single beat. Why is this different from our traditional measurements of blood pressure, heart rate, pulses, mental status, urine output? Well, it's different because it's in real time. It's measuring as it's happening to the patient. The other traditional measurements, while extremely important to get a global picture of the clinical presentation of our patient, and they remain important, this dives a little deeper into answering the question we ask every single day with every single patient at the bedside, and that is our patient adequately perfusing? That's it. When I walk into a patient's room, I work at a level 1 trauma center, and all this stuff is going on. I always ask myself and whoever I'm standing next to, is the patient perfusing adequately? And this helps drill us down and keep us focused on exactly how we're accomplishing and what we're trying to accomplish. This technology does require a blood pressure cuff and finger cuff. It's well validated in the intubated and non-intubated patients, so it can be very valuable, for example, during a rapid response on one of the floors, or perhaps even in the emergency department. It's a great tool for guiding your patient's response to fluid and vasopressors, and it can provide trends. If the absolute numbers are off, or I shouldn't say off, but let's say folks don't believe them, I have and work with some excellent providers that walk in the room and they grumble, what is that black box? I don't believe in that thing. And perhaps you do too. And that's okay. That's totally fine. We could argue, well, let's follow the trends and see how the measurements are changing as we are either giving fluids, blood products, and or medications. This is what it looks like. It is a multi-patient reusable finger cuff. It comes in 3 sizes, small through large. Small is very appropriate. It works nicely in the pediatric patient as long as it fits properly. It does have 2 dual chambers, meaning the pressure on one finger alternates between the adjacent finger, which is nice, so the individual does not experience continuous pressure on one individual finger. It's very quick and easy to set up. It allows for continuous and or with intermittent assessments. It is a surrogate for a blood pressure, which is typically taken in the brachial artery. However, it can be also entered manually. Now, there's some considerations, of course, that need to be thought of when using the finger cuff, is you do need to have continuous perfusing digits. The beauty of LiDCO is if it being the finger cuff, cannot sense accurate blood flow in the fingers, it will show you this on the software screen and is basically saying, do not use me. I, in my own experience, have found that clinicians will keep trying to cycle it over and over again, and they say it doesn't work. And I said, well, you're right, but it's telling you don't use me because it's not appropriate for this particular patient. You can try, of course, changing to the alternative hand, and there you may have success with the infrared sensors seeing blood flow. It uses the volume clamp method, and here you can see actually how the pressure chambers and the infrared light work. As I mentioned earlier, it alternates from one finger to another, so pressure is not induced onto just one finger only. And once again, as I said, it is a surrogate for a arterial blood pressure. So how does LiDCO work? It is a proprietary algorithm that uses pulse power analysis. It's looking at the entire pulse, the entire amount of blood within that heart cycle of systole and including diastole, which you can see here in the shaded area. It's beat to beat. It's in real time. It's exactly like looking at the bedside monitor of someone's heart rate or their arterial line. You know that, at least electronically, what you're seeing the patient is experiencing. Post-contour analysis also assesses the morphology of the A wave, but in this case, it is limited only in that it is looking at the systolic cycle of the heart, as indicated here in the shaded area to the dicrotic notch. So looking at the entire stroke volume, and that's what we're talking about here, the entire stroke volume for the heart is extremely valuable when we're considering it measuring that area for us to determine cardiac output. These are traditional measurements of perfusion that remain extremely important in painting that clinical picture of how our patient is presenting. Heart rate, is it compensating? Can it compensate? Is the patient on medications for their heart that would keep it from compensating? The blood pressure, is it high, low? What is the baseline? Urine output. We know the kidneys are exquisitely sensitive to a hyperperfused state. Central venous pressure. The thing with central venous pressure is we need to be cognizant that there's a lot of things that can elevate central venous pressure that have nothing to do with volume. So please keep this in mind. For example, right heart failure, high mechanical ventilatory pressures can all raise central venous pressure that have absolutely nothing to do with volume. Mental status changes. This is helpful to know. What is the patient's baseline? Again, very, very helpful, especially in the geriatric patient and even in the pediatric patient when their affect changes profoundly. Pulses. Are they better? Are they worse? Do we now have to use a Doppler to feel them? And then trends, of course, from baseline. And this is always a little tricky, is what is our patient's baseline? Because we don't always know. So still very important for us to consider all these measurements and these presentations when resuscitating our patients. So what's the big deal? What's the big deal about static indices of perfusion, of which I just previously mentioned to you? Static meaning snapshots in time. They're not continuous. They're not beat to beat. We measure, we turn, we go to the computer, we put the measure into the computer, and then we sit back and go, Dynamic measurements of perfusion, also synonymous with that would be functional hemodynamics. The difference being is that they are beat to beat, and it's that what's really cool about that is that when we give a fluid bolus or we're titrating, say, norepinephrine, we can see through the measurements immediately how the patient is responding. So let's do a case review and kind of apply these concepts to this particular gentleman. This individual was admitted from a skilled nursing facility who he had been a resident there directly to our ICU. He was in clearly respiratory distress, and we suspected urosepsis. He had contractures of the bilateral and upper extremities that were historical from his quadriplegia of 27 years, and he had absolutely no intake in the past 24 hours. His history was, besides the quadriplegia, was hypertension and hyperlipidemia. And here are his, excuse me, his vital signs. Heart rate is 90. Baseline is normally 50. His blood pressure is 101/56 with a MAP of 73. His respirations are 35. He is on a non-rebreather with SpO2 of 80% and a temperature of 39 degrees Celsius. So just looking at these numbers and looking at his history and his presentation, what do you think? Do you think he needs help? Do you think we need to do something to help him out? Well, yes, absolutely. His vital signs are telling us that his heart he's tachycardic. He is breathing extremely fast, and we know without even doing any labs that that could be an indicator of blowing off CO2 to try to maintain his pH. He could clearly be in urosepsis, and even on a 100% non-rebreather, his SpO2 is inadequate. So right there, I can see with the temperature, he is hypoperfused. No, we're not too sure exactly why. We're suspicious. So what we did was we went ahead and put the CNAP finger cuff on this patient, and you can see there in the upper right-hand corner the blood pressure and his heart rate, as I previously showed you on the last slide. But now we have more information. We have stroke volume. 55. We have a cardiac output being measured, 4.8. Stroke volume again times heart rate equals cardiac output. We have systemic vascular resistance of 1056. These are really helpful numbers to see because all of these are extremely low. 55 is below normal, as for your recall, it's 60 to 100 is normal for stroke volume. 4.8 is extremely low for a cardiac output, and 1056, 800 to 1200 is about normal, is running about the middle there of normal. But what's important about this is being measured beat to beat. Okay, so we know with just looking at his blood pressure and heart rate, one could think maybe he's doing okay. But certainly looking at these numbers and with the clinical, in conjunction with the clinical presentation of our patient, he clearly is not compensating and certainly not adequately perfusing. Given these numbers and his clinical presentation, we immediately gave him a 500 milliliter fluid bolus. We know through multiple research studies that if a patient's stroke volume increases by 10% after giving a fluid challenge, and in this case it was 500 milliliters, we know that they are responsive to fluid. And you can see here on the right side here that that's in fact exactly what happened. We want to make sure that our patient is on the ascending curve, or the curve here down on the lower right hand corner where it says between the points of A and B, that the patient is, if given fluid, they in fact will, yes, increase stroke volume. As we give preload, we will increase stroke volume. And that's exactly what happened. As you can see here, the stroke volume went from 55 to 62%, which resulted in a cardiac output of 5.5. Time we were giving him bolus, we were preparing to intubate him. So it is now 17:08, and everyone's looking at his blood pressure, and they're like, "Oh, what's going on?" And so it was a little perplexing. So the traditional cuff was cycling during this period. We couldn't see that 68/41 with a MAP of 49. It was cycling. And so LiDCO, in this case, CNAP technology, was able to give us immediately beat-to-beat blood pressure change, saying this guy is in a lot of trouble. So we went ahead and intubated him. And you could see that during intubation, he dumped. He went right over the edge. His stroke volume went from 60s down to 38. His cardiac output went down to 2.2, which I would consider, these are non-perfusing numbers. These are life-threatening. And without having this monitor on this man, we would have been, yes, worried about a blood pressure, but may have not known the gravity of the situation as far as how poorly perfusing. Now, when we go ahead and think about stroke volume, we have to consider the components of stroke volume. So his stroke volume is dumping. It's 38. He has no forward flow, but what is it? Is it preload? Is it the volume of blood in diastole? Is it afterload? Is it the resistance of the heart, which we measure with systemic vascular resistance? The resistance of the heart must overcome to eject blood. Is it the heart? Is his heart taking a hit? Does he just simply not have the force to pump fluid through, or excuse me, blood through the heart to for the continuum of forward flow? And we don't know, but we do know that when we look at stroke volume, we look at it in that order. We look at it in the preload, afterload, and contractility in that order, because if we have no preload, we can't address the afterload or the contractility. Consequently, we gave our patient another 500 cc bolus, and you can see here in real time that the stroke volume came up to 60. The cardiac output is now 4.2, and his SVR is now 903, so he's not clamped down quite so much. But notable is his blood pressure is lagging behind a little bit here, and certainly appears to be in a poor perfusion state. So one could argue, wow, let's give this guy another bolus because he likes fluid. However, with this technology in beat to beat and in real time, his stroke volume and cardiac output are coming up so nicely. Do we want to give him more fluid? How do we know if he's going to respond to fluid? Should we start a vasopressor? And how do we know? Well, we have another tool now. We have stroke volume variation, also known as pulse pressure variation. And this is measuring the circulation of the blood as it goes through the heart and the pulmonary tree, and the difference of the waveform that is being created by positive pressure ventilation. We often call this the ventilatory waveform. And we know through numerous research, the deeper that waveform, more than say 13%, for example, the patient would be most likely to respond to fluid. Conversely, if that waveform is flatter, the patient would be less likely to respond to fluid, and in this case, it's less than 10%. So our patient may or may not respond to fluid, but is on the side of most likely not responding to fluid. Yet we're still concerned about his perfusion. So, what are we going to do about that? Well, it might be an indication that we start a vasopressor. Keep in mind, blood pressure is tone. It's either obtained by volume or it's obtained by giving medication, as in a vasopressor. One thing that's really important, though, for this number, stroke volume variation measurement, not a number, but a measurement to be valid, is your patient needs to have the following criteria. They do need to be intubated. They need to have a closed chest with an intact diaphragm. They need to be on a positive pressure ventilatory mode of ideally 8 cc's per kilo, although some studies have shown validity with 6 cc's per kilo. They need to be riding the vent, in other words, not taking spontaneous breaths, and they need to have a regular heartbeat. So keeping that criteria in mind is very important if you're going to be depending on this measurement. So let's do a quick review of what, in this case, CNAP can help us with at the bedside, continuous non-invasive arterial pressure using the finger cuff. We can measure heart rate. We don't need this particular technology to measure heart rate, but what we do need is it to measure stroke volume. Stroke volume times heart rate equals cardiac output. This is beat to beat. It's in real time. We can also measure systemic vascular resistance. This is pretty important in the relativity of how hard the heart is working. I was just at the bedside just the other day, and the cardiac output was, I don't know, like 3.5, and the SVR was about 750. And this was extraordinarily concerning to me because I would have expected the heart rate, or excuse me, the output, cardiac output, to be much higher, given that it was beating against hardly any resistance. And so immediately, red flag went up, and going, oh man, there's something going on with this heart, as it was definitely performing suboptimally. And then that helps us go, well, we got to go in a little further and do some more diagnostics on this particular person's heart function. We can also measure, besides performance, we can measure fluid responsiveness. And I alluded to stroke volume variation and pulse pressure variation on the previous slide. And we can use it if we know the variation of that waveform is more than 13%, that more than likely the patient will respond to fluid. Or, as I alluded to also, we could see a difference if we decide to use vasopressor to create tone for our blood pressure and our ability to get forward flow. Remember the criteria I spoke of earlier of the keeping this to be a valid, having this as a valid number. In the absence of those criteria, intubated 8 cc's per kilo, closed chest, right in the vent, positively ventilated, we can use passive leg raise or a fluid challenge to determine if our patient will respond to fluid. Passive leg raise, you need technology like this to measure stroke volume. If it's greater than 10%, you're like, okay, great. If we think our patient needs fluid, by all the other clinical signs, we can trust that the stroke volume will go up. The fluid challenge was demonstrated earlier in the case study. We did it twice. And in fact, we did increase stroke volume. And it was very helpful for us to know that we were giving the patient fluid that it could receive and produce forward flow rather than having fluid go somewhere else, such as the lungs, if we're guessing real time. So how does this work, these functional hemodynamics of stroke volume or pulse pressure variation? What we do is we take a ventilatory breath. You can see here on this particular slide. And as we have this positive pressure being exerted to our pleural space, it compresses our interthoracic area, which increases the pressure, which increases the central venous pressure because it's decreasing venous forward flow. It then decreases right ventricular preload. It then reduces right ventricular stroke volume. And then there's a transient time of the blood circulating through the cardiac and pulmonary circulation. That's usually about 2 to 3 beats, which transcends to the left ventricular preload decreasing, left stroke volume decreasing, resulting in a lowering pulse pressure, a lowering systolic blood pressure, and therefore a lowering stroke volume. This is another picture of another way of looking at it. And what we're interested in here, as you can see during expiration and inspiration, how the lungs are, in the pleural space specifically, are compressing the lungs and therefore the circulation of the cardiac and pulmonary tree. It is, if we have an arterial line, you can see there that we have the waveform, and we call it ventilatory waveform, and this is exactly how it would look on your bedside monitor. And what we're not really interested in is the absolute numbers of, say, systolic and diastolic pressure here, but we're looking at the difference between the maximum of the systolic and the minimum systolic blood pressure, or in this case, pulse pressure or stroke volume. They're all very synonymous as far as conceptually of what they're giving us. So the deeper the wave, the higher the percentage, which makes sense. The deeper the wave, the higher the percentage, which is an indicator that the patient would respond to fluid, versus the more shallow the wave, or less than 10%, the least likely the patient. So it's important for us not to be guessing on if our patient's going to respond or not. We can use all of our clinical knowledge and expertise to determine if a patient needs fluid, but the next part of the question is, will they respond? What you're looking at here is the Frank-Starling curve, or also known as the ventricular function curve. And what we're trying to determine, and what stroke volume variation and pulse pressure variation can tell us. So for example, if the pulse pressure variation was more than 13%, we can assume the patient is in this area of the curve. Is that in fact they are on the ascending part of the curve? They will respond to fluid, okay? If the number is less than 10%, so that the ventilatory waveform is flattening, and we give fluid, the patient will not respond. And where is that fluid going to go? Well, it typically goes to the lungs. And if we are measuring cardiac output at the same time, you would actually see a dip in the cardiac output. Okay, so back to our patient. This is, again, the same screenshot that we looked at before after his 500 cc bolus, second one. He is intubated now, and he's been in the hospital for what, about 25 minutes or so. And so let's march it out here. So his blood pressure clearly is suboptimal. 72/43 with a map of 52. His heart rate's 70. It's normally 50, so it's still trying to compensate. His stroke volume is 60. 70 times 60 equals 4.2, and his SVR there is 903. Okay, so what do you want to do? Do you want to give him another bolus? You want to sit back and hang out for a while? Keep in mind, now that he's intubated, we can use the measurement of stroke volume variation to help us determine if we think he needs fluid, will he respond? These are two very, very different questions. So everything's telling me he needs something. He needs fluid or he needs tone. Now, he's on the flattening part of the ventilatory waveform. He's at the top of the Frank-Starling curve, which means he's in the non-responder section of that curve. So what are we going to do? Well, let's give him a vasopressor. Let's give him a vasopressor and see how he does with that. I'm concerned if we give fluid by just looking at his blood pressure, is we are going to we're on the flattening part of that curve, and in fact he will not respond, but in fact we will be doing him more harm. So let's see what happens. So we decide to start a vasopressor. All indications say to us that he's no longer responsive to fluid, but he is still hyperperfused. And so what we do is we start a vasopressor. We create that tone, and you can see our patient has responded very nicely. And we look at just his blood pressure, and yes, his blood pressure is going up, but more importantly than that, the much more sensitive measurement of stroke volume, that is also coming up, and now with a cardiac output of 4.9, this is looking like he's responding to the vasopressor. And isn't this curious that his stroke volume variation is now 17%. So once again, we have to ask the question, does our patient still need fluid? Does he need more pressor? And will he respond if we give that? Well, according to his stroke volume variation, he will be responsive. But the first question we need to ask is, just looking at these numbers, do you still want to do something? So, what do you think? Now, some may argue, well, let's go ahead and give him some more fluid. Or some may argue, well, let's titrate up. In this case, we started norepinephrine. Let's titrate up the norepinephrine. Well, what we actually did was nothing. I know this is a novel concept. I find it novel at the bedside. I think we are in a very time-sensitive business. And, you have this guy crumping in front of you, and you want to do something as quickly, as fast as possible. Although I do believe it's prudent sometimes that we just stop, we wait, we let the patient declare him or herself, and just let them equilibrate. And that's exactly what we did. And you can see here, by continuing with not titrating the norepinephrine drip, that the numbers look pretty good. But more importantly, our patient was looking better. And more importantly, collectively, these numbers are looking better. If we just isolated one number as we went through this case study, I believe it would have taken us down a path where we may have not managed the patient as quickly and or as effectively or efficiently. So let's review the objectives. Did we identify a patient who could benefit from non-invasive hemodynamic monitoring? Well, we did. We identified a patient who had perfusing digits, who clearly needed to have more than a blood pressure and a heart rate to monitor him as indicated during the intubation process and his response to fluid. We also described 2 hemodynamic functional assessments for providing guided fluid resuscitation, and that was in this case stroke volume variation, also pulse pressure variation, stroke volume, and cardiac output as provided by the proprietary algorithm of LiDCO. Thank you so much, and I hope this helps you go back to your facilities with a new curiosity about technology, and just keep asking those questions. Is my patient perfusing? Adequately perfusing? Do I think they need fluid or tone? And if so, very different question, will they respond? Enjoy NTI.